but I like that it's quick to install and it's reasonably strong and it's a reliable implant.
Oh, no doubt it's the ease of application and the ease of teaching, much quicker than a suture technique. I've actually just literally 5 minutes ago finished teaching a resident the 4-strand lock cruciate technique, and even after I've done hundreds of them, it's still a complex suture, and to teach a junior resident or even a mid-level resident that technique and see them do it properly is tricky, whereas anybody can fire the TR device.
The best part about it is it's so easy to put in. It's just like putting in a staple. It's quicker and easier to do than a flexor tendon repair with a suture. So the ease of inserting it is the best thing. And then the strength of it, allowing you to do more aggressive, earlier rehab, is another benefit that I like.
Yes, the answer to that would be I would like to have it available in the OR, in the hand consignment cart, and have it available to peel back if necessary. So my feeling is that I would probably use it more than not. And if I felt that after doing the full dissection, exposing the tendon, bringing the two ends together, if it looked like it was going to be an easy application of the TR as compared to the suture, I would definitely use the TR every time. But sometimes it can be a bit distal and can be tricky to get enough working length distally, and then I'll probably go for the suture. So more zone 1s probably go for the suture, but closer to zone 2 and definite zone 2s go for the TR device.
Yes, I definitely would. It's much easier than the traditional suture technique. It saves time in the OR, it's a quicker device to put in, and it's definitely stronger, we think, definitely proved in the lab studies. So yeah, those 3 reasons: it's quicker, it's easier, and it's stronger. I would definitely use it in every zone 2 device, zone 2 flexor tendon repair.
I would consider not using it in the finger zone 1 to 4 extensor tendons, as it's quite superficial and it might be slightly bulky for these areas.
Absolutely. I think that if the suture zone of injury is quite distal, you need a working length to be able to get the 2 tines of the TR device underneath and still get the deployment mechanism central, and there just isn't enough space in those small tendons, especially the more distal ones like zone 1.
If a very oblique laceration in the tendon, it makes it tricky to use. If you're too close to the vincula distally, or if you are approximately too close or really under the A1, A2 area, it might be difficult to put in. And then also, obviously, if there's any open wound or risk of sepsis, I would be particularly worried about putting the device in.
I would use TR in all zone 4 to 2 injuries on the flexor side, and because it's quite reliable and strong.
I think it would be awesome to be able to use TR for multiple tendons such as zone 3, but especially zone 4 and zone 5, where you've got a confined space and you've got lots of tendons to do in a limited amount of time. It would be fantastic just to apply the TR device.
But I think it would be very useful in zone 3 and 4 and essentially in zone 5 lacerations. I think that the more space you have available, the easier it'll glide, the better it will perform, and it being a very nice strong repair, I think that it'll be very, very useful.
In our study, we just did it in the zone 2, but I would definitely use it in all flexor tendon repairs, zones 2, 3, 4, 5. Zone 1 may be a bit distal, it may not be able to be used there, but definitely all flexor tendons I would use it in, and potentially extensor tendons as well.
I would consider resistance training much earlier, and I would consider moving the patients much earlier as the repair is strong and reliable.
Well, I think certainly I would. I think that it's a very, very strong repair. There's no gapping, there's no stretch in the construct, and the way you put it in, you sort of have a bit of bunching at the tendon repair site. So I think that a even more aggressive rehab protocol would be very effective in getting the best out of this device.
Yes, I think so. At the moment, our protocol would be 4 weeks immobilization. I think with the strength of the repair with the TR device, I think it would be reasonable to do a more aggressive rehab protocol, less splinting, more motion. And I think that would then translate into getting the patient quicker back to work, quicker back to sports, and a better outcome. Yes, I definitely introduced them to the device. I wouldn't, they obviously need to learn the suture repair technique as well, but I'd show them the device and teach them to use it. And I think a big benefit of this device potentially could be in the hands of non-hand surgeons doing a flexor tendon repair, possibly in an area where there's no hand surgeon available. So I think if all residents learn how to use this device and then they become occasional hand surgeons, I think the results of a flexor tendon repair would be better with them using this device than doing a complicated 4-strand or 6-strand repair.
The normal suturing techniques has a steep learning curve, and it's very important for the registrars to learn how to do normal suturing, because the TR might not always be available, but I'll definitely include training them in the use of TR. From our trial, we haven't picked up any problems, and it's as reliable, if not more, than normal suturing technique, and it's definitely faster in my hands.
No, I think it's a fantastic device. It's strong, it's low profile, and as the trial shows, it gets good results. It's a lot easier to apply than a suture technique for an average surgeon who doesn't do a lot of hand surgery. It's much easier. Obviously, is there one concern? It's going to be, I would imagine, in a resource-constrained environment like ours, it's going to be the cost. So that'll have to be addressed.
None at all. I think it's an excellent product, really good, easy to put in, and I would want to use it in every case that I do in the future.
I was unable to tell the difference between the 4-strand repair and the device, as there was no unusual restrictions and no unusual discomfort.
Yes, I think for most of the time my guesses were correct. This was mainly because patients that had the device definitely started to recover much quicker in the first 4 weeks, and I noticed that the glide was much better and that they had greater range of motion than in my other protocols that I have followed.
Because the CoNextions device is holding the tendon more securely, it will be possible to accelerate the rehab process. Firstly, by allowing for more active flexion earlier on, and this will mean better glide and fewer adhesions. Secondly, the splint will be on for less time, and it will be more comfortable, as it won't need to be in so much flexion.
Yes, I think for sure. Remember, aggressive therapy does not mean pushing harder or forcing a tendon. It means that you can start mobilization earlier, and this is the advantage with the TR.